Good afternoon, everyone. It is my pleasure to welcome you to this year's annual John Lindenbaum Memorial Lecture. It's also the time when we have an opportunity to welcome and to enjoy with Dr. Lindenbaum's wife a celebration of his legacy. I'm going to say just a word or two about Dr. Shirley Lindenbaum, who has been a supporter both of this lecture series, but of our students, and then turn the podium over to Interim Dean McKiernan, who will talk a little bit more about Dr. John Lindenbaum, as well as introduce our speaker this afternoon. So Dr. Shirley Lindenbaum is a renowned medical anthropologist herself, who was part of the team that discovered the cause and the method of transmission of the prion disease, and really led to the discovery of the research that discovered the form, the epidemiological form of the prion, and also was a signal discovery that joined social sciences and epidemiological research to biomedical research in understanding epidemics and their transmission. So we welcome Dr. Shirley Lindenbaum once more and enjoy her presence. And we welcome you to hear this lecture by our speaker in memory of Dr. John Lindenbaum, who really is legendary here at the Bachelor's College of Physicians and Surgeons. So I'm going to turn the podium over to Interim Dean McKiernan, who will talk about Dr. John Lindenbaum and then introduce our speaker. Jim?
Thank you. Thanks, Anna. Appreciate it. Appreciate everybody turning out today. I know it's been a series of a week or two of some pretty significant activity with the interaction between academic medicine and the government. So I think I'd like to take this opportunity to bring everybody together for a moment of just simply reflecting on what the impact of an academic medical center and an amazing, incredible leader and investigator can have on the world around us, and really soak that up. So I'm really looking forward to it. I did have an opportunity an honor really, to be a student here from 1989 to 1993 and had the pleasure of being in the classroom with Dr. John Lindenbaum, on the wards with him. And I don't know how many people in the room are old enough to actually know him or have met him. I see one hand going up there. Yeah, when Anne was describing the history of the lecture, I haven't attended the lecture as a faculty member much in the past, but it brought back immediate memories. He, for those of you who knew him, was a master clinician in hematology and an incredible scientist and educator in the area of B12 and folate metabolism. I can remember literally distinctly learning the pathway of intrinsic factor and the terminal ileum and the absorption of B12. And Ali will be impressed. It's linked to macrocytic anemia and neurological decline with B12 deficiency. Did I get that right? I didn't even go back and read my notes, but he had that kind of effect. That was 30 plus years ago. And actually, went on to a field of medicine where we do surgery on the terminal ileum, and still to this day I check B12 levels in all my patients because of Dr. Lindenbaum. He had that kind of a lasting impression, and so it's an honor to be here in a lecture in his honor and named after him. It's even a bigger honor to introduce this year's annual speaker, who actually needs no introduction whatsoever, particularly in our environment and our campus, but Dr. Wafaa El-Sadr, who has been an amazing leader in global health for her entire career. We actually heard earlier today her influence on our new interim dean of the dental school, who happens to be here in the room, Dennis, recounting his encounters with her at Harlem Hospital as the chief of infectious disease. That dates back to the early 1990s, but really an expert in infectious disease and global health, the current leader of the ICAP, or International Center for the Advancement of Treatment and Prevention of AIDS and HIV in Africa, has led initiatives in both the U.S. and Africa for the protection and implementation of systems to protect the most sensitive and the most vulnerable populations in areas that are affected by tuberculosis, HIV, as well as malignancies throughout the world in 40 different countries, currently active in predominantly sub-Saharan Africa. I will tell one brief anecdote of how I met Wafaa, if it's okay. I'm sure she remembers this. I'm just, for those of you who don't know, I'm a urologist by training, so you might wonder exactly how I'd ever have had the pleasure or honor to meet Wafaa El-Sadr. But about 10 or more years ago, there was some concern regarding the ICAP program in Africa, and this particular program in voluntary adult male circumcision, which happens to be an extremely effective measure to reduce HIV transmission in endemic areas. And there was some concern regarding the surgical programs that were developing in these areas. And someone, I think in the board or somewhere here at Columbia, said, we can't do this unless a surgeon or urologist on the staff somehow vouches for the program and says that it's okay, because there's no surgeons in the School of Public Health. Was lucky enough to have one of our faculty who actually had done some mission work in the area, who's very engaged and partnered with Wafaa, and essentially said, I'd be happy to be the surgical quality officer, whatever they require. He said, what's the scale? What are we talking about, the number of circumcisions? And he said, well, last year was around 500,000. Can you oversee this program here from the United States and fly over once in a while to Mozambique and make sure everything's okay? So he agreed to do it, by the way. This is Joel DeCastro. I don't know if he's in the audience. If he is, and we may hear some of that today, I imagine. But just an amazing opportunity to meet an amazing leader and someone that we've been lucky to have amongst our community, and obviously lucky to have here today. So without further ado, I'll introduce Professor Wafaa El-Sadr as the John Lindenbaum Lecturer. Thank you, Wafaa.
Thank you very much, and it's really an honor to be here and to give this lecture in memory of John Lindenbaum. So in 1988, I actually went to Harlem Hospital to take the position of Chief of Infectious Diseases. That's like 37 years ago. Is that possible? And when I got there, there were these legendary people that everybody talks about. In hospital, people talk about these legends. And one of the legends was John Lindenbaum. People would talk about John Lindenbaum as a true legend. There were also Jerry Thompson. There were all these legendary people that walked the hallways in Harlem Hospital, and so many other wonderful people, and several of them are in the audience today. Many of them have retired, and I'm the only one who's still working, so I'm wondering what it's all about. But, Harlem Hospital played a very important part in my career, a very formative part in my career. And I think I have to say that the people I met at Harlem Hospital have stayed friends forever, and Elaine Abrams is my dear friends and colleagues to this day, and we still continue to work together every day. So surely it's a pleasure to see you and to do this in the honor of John. And I also remember your work on HIV as well in the early days. So thank you for being here. Okay, so for starters, I entitled my talk, Can HIV Transform Global Health? And I hope to walk you through a narrative, a story about the HIV epidemic, particularly the early days, the response to the HIV epidemic, what has been achieved, and also what we can learn and how the lessons we've learned can inform the way forward for global health overall. I have no financial relationships to disclose. So here's an outline of my presentation. I'm going to speak first about what I call the dark years of the HIV epidemic. Then I'm going to switch to what I've also called a public health triumph. I'll then touch on the evolving global health challenges that we face as a community, including the continued HIV epidemic, and summarize a bit the lessons from HIV. Then at the end, I'm going to reflect on the current moment in this country and around the world and end with some conclusions. So let's start first with the dark years. So of course, as you're well aware, many of you in this audience, the HIV epidemic has had a huge impact on the world overall. And just in the early 2000s, there were an estimated 36 million people who were living with HIV at that time, and nearly 22 million lives of people had died from HIV. And in many parts of the world, there was, of course, no treatment and no hope for these individuals and no hope for these communities. there were dire predictions for what would happen, particularly what would happen in sub-Saharan Africa. And as you can see here from some of these, what you see on the slide, some of the clip notes, some of the reports, children at the brink, in addition to, for example, Africa's use on the edge of a chasm. In addition, of course, the UN said here at that time that they predicted that up to half of teenagers in Africa would die of AIDS. So these were really dire years in terms of the future, the present as well as the future of the continent. And as you can see here in looking at the epidemiology in those years, you can see here, of course, that the estimated numbers of new infections by region is the vast number, the highest number of new infections were reported from sub-Saharan Africa, and as well as you can see here from Southern and Eastern Asia and other parts of the world. But certainly sub-Saharan Africa was the part of the world that was bearing the brunt of the HIV epidemic. And you could see this in the figure on the right here. And this figure shows the change in life expectancy over time from 1950 till 2000. And on the y-axis are life expectancy in years. And you can see in this figure that several African countries since the 1950s were making really good strides in terms of achieving longer life expectancy. And then you'll see what happens here in the 1980s and early 1990s in countries with high HIV prevalence like Zimbabwe, South Africa, Botswana. You'll see that there was almost a plummeting in terms of life expectancy, an abrupt and dramatic loss of all the gains that they had achieved over the past many decades. And you can contrast that with other African countries that had low prevalence, where they continued to make progress in terms of life expectancy. So the impact of HIV was very profound, as noted in this slide. There was also, in addition to, of course, the lives lost and the suffering in communities, there was also a huge economic toll on the countries themselves, and because of the effects on people's livelihoods, communities, productivity, and development. Now, at the same time, while Africa in particular was facing this dire epidemic and with its consequences, the health systems in many countries were in crisis. And these are just a few photographs that we've taken of some of the conditions in many of these places. You can see here, this is a crowded clinic actually in Mozambique with people, a dilapidated facility, but with people crowding outside trying to seek any care at all. You'll see here a laboratory, again, the condition of a laboratory. You'll see an outpatient clinic with crowding and people sitting on the floors, and hospital beds with people, more than one person, often in a bed, and people lying on the floor. And this is what's supposed to have been a pharmacy and a health facility. So in essence, these countries were facing an enormous challenge, while at the same time, these health systems were quite fragile and really were largely able to deliver the most basic acute care. Just a person comes in, they have an acute need, and they get whatever they're needed, but there was no continuity of care at all for a chronic disease like HIV. What happened next? I think what happened next can truly be described as a public health triumph. So in the mid-1990s and 1996, effective treatment for HIV was identified. And this was essentially what people have called the HIV treatment cocktail, which are effective antiretroviral drugs that almost overnight could transform, for people who had access to the drugs, could transform HIV from a death sentence into a chronic manageable condition. But of course, 90% at that time, 90% of people with HIV worldwide had no access to these life-saving drugs. And you can see here on this figure here is that in sub-Saharan Africa, in this on this side of the figure, these are the numbers of people, deaths in thousands. And this is just this small number of people who get access to antiretroviral therapy. And you can contrast that with the number of people in high-income countries here who had access to antiretroviral therapy. So where people were dying, they were dying because, of course, they had no access to treatment. So this was the situation at that point in time. What happened then, which is obviously a remarkable lesson, was a global mobilization. And this global mobilization was really led often by people with HIV themselves, who mobilized to advocate for themselves and their communities, as well as other people who supported them. And out of this came, of course, a huge mobilization around the world, a declaration of commitment on HIV that actually was from the General Assembly, the United Nations General Assembly. And this mobilization was the catalyst to what we saw thereafter. So what happened, I think almost somehow miraculously, but it wasn't miraculously because I tell you how soon, but you can see that over time, this is at the end of 2002, this number of people receiving antiretroviral therapy in millions. And you'll see over time here until 2011 or so, just the rapid increase in the numbers of people accessing treatment. And what's even most impressive is what you see here in the gray, is that the vast majority of these individuals were in sub-Saharan Africa, where the epidemic was, of course, the most severe. What was the effect of this rapid scale-up of treatment? You can see it here in this figure on the right, and this is now coming up to 2022. And this is, you can see that these are the maroon color are numbers of HIV-related deaths, and in the blue, you'll see the total number of deaths that have been averted through treatment in millions. So antiretroviral therapy, in a way, transformed, as similar to what it did in high-income countries, the same remarkable effect was noted in some of the poorest countries in the world. Now, what happened at a population level? Because ultimately, you want to see what happens at scale. And here you'll see very dramatically what was the effect of the scale-up of treatment. If you look at some of the same countries that had this plummeting in terms of life expectancy, again on the y-axis, you'll see that with the advent of antiretroviral therapy and access to these HIV treatment, you'll see some of the countries that most severely affected were more severely affected by HIV and had very high burden of disease. You'll see that they started gaining again some of the losses they had in life expectancy. And this is you almost never see public health intervention when you see a dramatic effect one way and then you see a remarkable recovery so rapidly. In addition, of course, there was also another triumph, which was the triumph of prevention of transmission of HIV, vertical transmission from mother to child. And you'll see here in this curve again what happened with new HIV cases in children and transmission from mother to child. And you'll see again the increase and then the rapid drop again with access to antiretroviral treatment for the pregnant woman, which we know is highly effective for prevention of transmission from mother to child. Now, this is about treatment, but let's talk about prevention in adults. And you'll see again, similarly, with the increase in access to HIV, to treatment, we know that treatment is not good. It's not just good for the individual, but also it decreases transmission from somebody who has HIV to their partner. So you'll see also the decrease in the numbers of new infections that happened, again, with the advent of antiretroviral therapy. However, you'll see that, again, the target that was for 2025 was to reach about 500,000 annual new infections of HIV. And as a global community, we did not reach that goal. The numbers of infections is still more than 1 million per year. Now, it's important to acknowledge that also HIV is not just an epidemic in sub-Saharan Africa, because people feel like it's out there somewhere and it's not really affecting their own community. If you look at the global epidemic as it is now, you'll see that here in this, about half of the cases, these are half of the new cases of HIV are occurring in sub-Saharan African countries, but you'll see that the other half are occurring elsewhere in the world, in Asia, the Caribbean, Latin America, and elsewhere. So we continue to see substantial numbers of new infections occurring certainly in sub-Saharan Africa, but also in many, many other parts of the world. Now, so I've describe to you what I think, what I've called the triumph of public health. But what are the challenges when we think about it? Is the HIV epidemic done? And should we turn the page and deal with some of the other global health threats? So I'll focus on the challenges ahead, both in terms of the HIV epidemic as well as beyond that. So you see here in this slide that again while there's been great progress in terms of in Africa and in response to HIV, much of the rest of the world is falling behind. And even in the United States, we are falling behind. And this is a paper with my colleague Jessica Justman sitting in the audience. We have not emulated what some African countries have been able to accomplish in terms of the scale up of treatment and the decrease in the numbers of cases. So when we look at where we're at today in terms of the HIV epidemic, it's estimated there are about 40 million people, adults and children, who are living with HIV. And what that means is that these are individuals. HIV is a chronic infection, and people who started on treatment must remain on treatment for life. We don't have a cure. So that moving forward, at least 40 million people need to continue on treatment for the duration of their life. That's important to keep in mind. In addition, it's estimated that nearly a quarter of people with HIV are not on treatment currently. So we've accomplished a lot, but we have a lot to accomplish. And 1 in 4 people living with HIV around the world are not accessing treatment today, which I think is shocking to people to appreciate this. What about in terms of new infections, prevention? So as I mentioned before, we still have about 1.3 million new infections every year occurring around the world. And the majority of these new infections are occurring in sub-Saharan Africa. You can see here West and Central Africa, about 190,000 per year, Eastern and Southern Africa, 45,000 per year. But of course, you can see as well, for example, in Asia and the Pacific region, 300,000 new infections per year. And in addition, of course, all other countries are facing, again, the threat of new ongoing transmission and new HIV infections. We also know that HIV infections, new infections, particularly affects certain populations. So if we think about adolescent girls and young women, and we look at sub-Saharan Africa, every week there are more than 3,000 new HIV infections amongst adolescent girls and young women just in sub-Saharan Africa alone. So we have a long way to go in terms of prevention of transmission. We also know that around the world, key populations are bearing the brunt of HIV. And by key populations, we mean specifically vulnerable populations, including men who have sex with men, sex workers, people who inject drugs, and other vulnerable groups, transgender people, are bearing the brunt of HIV. Now, you see here, just to show you as an example of the evidence to support this statement, this here in the slide, you see comparison of HIV prevalence in these populations versus the general population overall. So if I start here with transgender people, these individuals have 15 times higher HIV prevalence than the general population. Gay men and other men who have sex with men, 11 times as high. People who inject drugs, 7 times higher, and sex workers, 4 times higher. So you can see that the brunt is often borne by populations that are particularly vulnerable, and also populations that often are discriminated against and have to face very punitive laws within their countries, often hindering their ability to access treatment and prevention. So this is where we're at with HIV and what the challenges ahead of us in responding to HIV. But let's focus about other health challenges also that are facing the world as we speak. The good news is that we have an aging population globally. So that's the good news. And in 2022, it was estimated that 10% of the world's population is 65% of age. Is 65% or older of age. It's estimated that by 2050, let's just go up to 2050, that about 16% of the population will be over the age of 65. And you can see that there are some countries, the projected aging of the population is certainly very high, including the United States, China, France, many other countries. Of course, for African countries, they're lagging behind. Even though there's improvement in life expectancy, they're lagging behind. And only by about 2100, they will have about 15% of the population being 65 years or older. And with an aging population, just requires also a transformation in the health system and in the delivery, in the shaping of the delivery of the health services for these populations. And one important issue is, of course, the threat of non-communicable diseases, which, as we all know, increase with older age. So you'll note here that it's anticipated that if you look at in blue here, this is death in terms of millions of individuals, that the dominance of death from cancers, death from ischemic heart disease, and also from cerebrovascular disease, these are going to dominate over the years, and particularly, of course, in countries where we have an increasingly aging population. We also have a global mental health crisis, another non-communicable disease. And it's estimated about 1 in 8 people around the world is living with a mental health condition. At the same time, we also have a crisis in terms of who can provide the care to these individuals. And this is looking at high-income countries and the numbers of mental health professionals who are available per 100,000 population, and contrast that in the high-income countries with low-income countries where there's barely anybody available to provide these services. So this is another non-communicable disease that's going to is a threat today and will be a growing threat as we move forward. At the same time, I talked about aging. At the same time, we also know there's a growth in youth and youth population, particularly in Africa. And in this figure, you'll see here that in sub-Saharan Africa, by 2050, sub-Saharan Africa will make up about 1/3 of the world's youth population. This means that we have to be prepared for how do we maintain the health and well-being of this young population as the numbers grow. And also that this young population as well may be more susceptible to other conditions, health conditions, for example, HIV, sexually transmitted infections, and other threats. So we have to be thinking about both the aging population, but also what's called the youth bulge in Africa that's happening now and is anticipated to grow over the years as well. Infectious diseases are not going away. I mentioned to you about HIV, but there's, of course, the emergence and re-emergence of infectious disease. And many of you, of course, in this room know about COVID-19. But if you look over the years, there have been these emerging infections that have come, and we've, including Ebola, there's now a current outbreak in Uganda and also in the DRC. And the threat of emerging infectious disease remains, of course, with us as we move forward. Another big threat from an infectious disease perspective is the threat of antimicrobial resistance, or AMR. And it's anticipated this is actually going to be one of the major causes of death as we move forward. And you can see here in this figure here is the predicted mortality from AMR in the pink here compared to other common causes of diseases. And you will see that it's very dominant, AMR, as well as the cancer-related death. So that's another infectious condition that's very important to think about as we move forward. And it's not only in developed countries where AMR is a threat, it's also in all countries around the world, including in sub-Saharan Africa and other low and middle income countries. Of course, one can't speak about what's happening, what's going to happen in terms of health of communities without thinking about climate and human health. And there are many ways in which climate change is affecting health in many ways. It could be through conditions that are sensitive to where there are vector-borne diseases like malaria, for example, other vector-borne conditions that are transmitted as these vectors spread and are encountered in new communities, new areas, geographic areas, but also, of course, injuries from related to extreme heat, as well as respiratory illnesses. Waterborne illnesses is another threat. And then, of course, the threat from non-communicable diseases and mental and psychological health. In addition, when people think about climate change, we also need to think about its impact on health systems and facilities, which is also very profound. And I think lastly, another threat that's very critical is the whole issue of human displacement, which is happening now more than ever. There are estimated to be 117 million people who are living in displacement globally. That's by the end of 2022. And this includes refugees, as well as internally displaced individuals, asylum seekers, and so on. And of course, these individuals are displaced because of various reasons, whether it be climate or wars and conflicts and so on. But they also have specific needs for their health as well. There are very unique needs that they have. So how are we going to deal with all of these health threats, and how are we going to continue to tackle HIV? And this is where we need to think about what have we learned from the HIV response. It's been a tremendous success, a triumph in many ways. But how was this accomplished? What are the lessons that we've learned that we could use and think of adapting to confront other threats that I went through and I shared with you very briefly? I think probably the most important reason why the world was successful, and particularly I would say sub-Saharan Africa, but other countries as well, have been successful in confronting HIV, is by focusing on health systems. It's very important from day one, and this includes for us at ICAP, when we founded ICAP now more than 20 years ago. From day one, we knew that it's not going to be, there is no magic bullet. It's not about treatment, the pill. It's about everything else that you need to have in place, that you need to transform in order to be able to get where you want to get to. And that means that you have to go beyond the magic bullet. You have to think of all different components of the health system. And for some of you who are not aware, this is not the healthcare system, this is the health system overall. So this includes, of course, the need to focus on human resources. Who are the people who are going to provide the services? What about the service delivery models themselves? What about having commodities, medications, for example, laboratory systems to be able to make diagnoses and monitor people, information systems to get the data to guide what we're doing and measure if we're successful or not, governance systems, the financing system, and most importantly, of course, you have to focus on the people who are the recipients of the services, the communities themselves, who are at the core of any successful program. So I'm going to very briefly walk you through what was done for HIV and invite you to think about how these could be adapted for some of the other health conditions that I mentioned. So in terms of human resources, let's start with that. I think one of the most important priorities from day one was strengthening of the workforce. And this has meant that we had to think outside the box. And it was very quickly realized very early in the epidemic, is the HIV epidemic, is that there certainly were not enough doctors anywhere to be able to scale up treatment, for example. And this required focusing on some of the lessons that were very important, the idea of task shifting, of actually thinking of the tasks that are delivered by a cadre of health workers and think about who you can shift this to, who can actually deliver these services appropriately. For example, shifting from doctors to nurses, or from nurses to outreach workers, community-based workers is very important. The idea of using multidisciplinary teams to deliver all of the services needed, as well as, of course, to increase the capacity of the workers themselves. Now, in terms of the service delivery, and this is what I mean by service delivery, what's the model? What's the approach? And it was a very important realization is HIV is a chronic disease. It's a chronic infectious disease. So you had to kind of transform the health system from giving acute care to being able to deliver chronic care. One realization, which I mentioned to you already, is we had to think beyond the magic bullet. had to think about what else is needed to be able to get to the outcomes that we desire. And that meant that we had to think about the needs of the people themselves. And this meant something called differentiated delivery service models, or DSD models, which are really trying to figure out, like, it's not just the what, it's not just the medicine and so on, it's also where is this going to be delivered, who's going to deliver it, and when is it optimally to be delivered. This was kind of a revelation because people were used to doing something exactly in the same way. This means that it was perfectly okay to deliver the services in the community and medications in the community, to have community groups and so on. And then also it could be delivered, the services could be delivered, like I said, by physicians, a nurse, a pharmacist, community worker, etc. So that was the model itself had to be changed in order to meet the needs of people. In addition to the model itself, there was an important component of the HIV success story is the rapid adoption of innovations and discoveries, very rapid adoption of discoveries. And for example, when antiretroviral therapy came along, there was again 1 pill a day was very fundamental to being able to scale up to millions. There was also rapid HIV testing that was discovered and could be done in the community, in people's homes. And then there was the prevention revolution with treatment equals prevention, as well as, of course, pre-exposure prophylaxis, where people who are at risk for HIV can take antiretroviral therapy to prevent acquisition of HIV. And then the different new models of innovations, like the DSD models that I mentioned to you before. And then most recently, long-acting. Now we have long-acting treatment where people can get intramuscular injection every 2 months for treatment of HIV, or they can actually get an injection again every 2 months for prevention of HIV. So there's both the models of how they're delivered, but also the importance of rapidly taking innovations and taking them to scale. And this was highly unusual, as most of the time, innovations usually kind of sat around, and it took years and years, if not decades, until they reached the people that they need to get to. In terms of commodities, I think very importantly was bringing down the prices of medications. And you can see here the medications, antiretroviral therapy used to cost about $12,000 a year. And now it's really almost less than $100 a year, much less than $100 a year. So it's the idea of how can we overcome the barriers in access to drugs? How can we bring the prices down and enable them to reach the people that need them? Laboratory systems are also very important, and probably one of the most important contributions of the HIV response has been that this has strengthened the laboratory systems for other conditions as well. And this was particularly helpful in terms of the response to COVID-19, where countries that had been severely affected by HIV and had invested in the laboratory systems, these countries were much better able to rapidly adopt COVID-19 diagnosis and be able to offer the testing to large numbers of individuals. So the investments in this component of the health system was also and is very important, not just for HIV, but I think it enables strengthening the health systems overall in these contexts. I mentioned the importance of information systems, and we take it for granted that data are important and medical records are important, but very importantly also we're setting targets and having a goal that communities needed to reach was very, very important, because that means that people were working towards targets that were set. And then data systems were put in place to measure the progress towards reaching those targets. And this meant that in many countries, the strengthening of the medical record systems and so on, as well as importantly, of course, being able to look at the data on a regular basis and be able to actually use the data to make decisions. And that was very, very important, and in many ways helped drive the progress to reaching the goals that have been set. Now, governance and political will. I think I should not underestimate the importance of political will. And I think, again, whether it be negative influence of politics, but also positive impact of politics. And also, I think, enabling the communities themselves to be part of the governance, to actually be an active part in shaping the response and being a part of the decision-making process from day one, sitting around the table, making decisions with the political leaders. All of this could not be done without having the resources and the funding. And I think the global mobilization enabled actually a large amount of funding that was generated to be able to achieve the targets and the goals that I mentioned to you already. And you can see here in this figure over time from 2000 until almost 2019 here, you'll see here that this is, again, the domestic spending, as you can see in the orange, but you can see, of course, the U.S. investment in the funding, increase in funding, that was very important in getting to the outcomes. Of course, you'll also notice there's been plateauing of the funding over the past several years, which means there's really, in reality, a decrease in the funding. And this is one of the threats that we face as we move forward, is the disinvestment in global health overall. And fundamentally, I think last but most importantly, is the focus on community. And that meant that the mantra in the HIV response has been nothing about us without us. And this has meant that you need to involve the community, you need to involve the people who are receiving the services and helping shape the response. And this has been very, very important. And I think in many ways has transformed how not only we tackle HIV, but I think also in many ways how communities are now trying to think about how do you tackle other non-communicable diseases or other conditions as well. I'm going to tell you a little bit about ICAP and our work there. This founded ICAP maybe with colleagues, with a handful of colleagues, maybe now more than 20 years ago. And I think our mission and our vision give you a sense of what we're aiming to do. And I always try to think about the vision first. The vision is for healthy people, empowered communities, and thriving societies. So we're focusing on the person, but also on the community and on the society overall. And the focus was to how do we transform the health of the populations? And it's focusing on innovation, research, as well as also partnership and collaboration. So these are the 4 pillars of our work. Overall, the intent is we need to put knowledge into action as quickly as possible. And this is through design, implementation, scale-up of service programs, expansion of education and mentorship programs and training, as well as measurement, impact measurements, surveillance, doing surveys, and very importantly, research is part and parcel of our commitment as well, in order to generate the knowledge that will then inform the service and the training and the measurements themselves. So as was mentioned by Jim, we're working now currently in more than 40 years across 5 continents, and you can see the map here. And we started out with a handful of people, 5 people, I remember, and now we have a global staff of about 2,400 people, including about 150 people here in New York, and the rest are located all over the world, and largely people from the countries themselves, from the nationals of the countries themselves. And you'll see that, of course, we have a large focus on sub-Saharan Africa, but not exclusively, Central Asia, Eastern Europe, Latin America, Central America, Southeast Asia. And we continue to have 2 research sites in New York, one in Harlem and one in the Bronx, because we're very big believers in the connection between the local and the global. So what have been our contributions to this success? So over the past 20 years or so, what have been the contributions of ICAP to this, to the HIV response? Till today, or maybe till about 6 months ago, ICAP has facilitated about 58 million people to get HIV tested. About 11 million people have been screened for tuberculosis. 2.5 million people have received HIV treatment. 13 million pregnant women have received HIV testing. You can see the large numbers of women who received antiretroviral therapy to prevent transmission to their babies. And then you can see the health system investment here, the numbers of health workers that have been trained. This is PrEP, access to PrEP, almost now reaching 500,000 people have access PrEP through services supported by ICAP. And then the numbers of health facilities supported and laboratories that have been supported. But I always need to stop here and say that the work that's been done is really the work, the most important aspect of the work has been the work that's been done in country and has been the work that's been done by the people from the countries themselves, because they're the ones who have invested the time and the effort, really blood, sweat, and tears to get to shape these programs and to be able to achieve these numbers. So I mentioned a focus on health systems and why it's important. So this is kind of a table that I think will give you a sense of where I'm going with this idea. So if you think about the HIV response, I mentioned already to you the importance of addressing the demand for services, the access, the workforce, the social support, the infrastructure, drugs and laboratory supplies, and community involvement. That's very fundamental, and that's really at the core of why these programs were successful. It's this idea that there's no magic bullet. But if you think about many of the other health threats that people in this room are dealing with every day, whether it be a chronic disease like diabetes or maternal health or child health or TB or others, it is the same when you think about it. If to achieve high quality and the outcomes we desire, we need to be thinking about all these elements of that need to be in place in order to achieve the outcomes we desire. I think it's impossible to be able to achieve what we want if people are not coming for the services. We don't have demand for the services, as simple as that. It's impossible to be able to achieve what we desire to achieve if the services are there, but people are not accessing it, and so on and so forth. So it's fundamental, but often we don't think that way. We don't think of all the different elements that must be there so we can get to the goals that we all desire. And certainly over the past 20 years in ICAP's work, we've expanded our work because we're cognizant that it's not just HIV, it's HIV plus remains a threat, but it's many, many other health threats. So our roots are definitely in HIV, treatment, prevention, and so on. But I think you can see over the years here from 2003 to 2023, in those 20 years, the expansion of the portfolio of work to include malaria, tuberculosis. You can see here, especially non-communicable diseases, aging, infection prevention, antimicrobial resistance, climate change and health, and many, many other global threats. And I think what we've always thought is that you need to use the same principles as you shape the response, as you shape programming for these other threats as they come along. I think I could not end this talk without trying to talk about the current moment and meeting the current moment. I think obviously for everybody in this room and listening wherever you are, everybody's quite cognizant of what's happening around us. And the moment is kind of alarming. I think you can see here a few things like the US and has withdrawn from World Health Organization, for example. And as I said in this article, it's an imperfect but an essential relationship. We only gain from the collaboration with the global community. So I think severing that connection to the World Health Organization does not bode well. Again, the threats to the funding of HIV programs is very real. And many of you have heard about this in the media and over the past several weeks. And I think, again, it hasn't only been HIV, but it's also been largely, restrictions and to funding for humanitarian assistance is one of them, to humanitarian, to migrants, to climate. I think this is it's across the board, I think, of alarm. And just today, I came across this article And these are colleagues who decided to do some modeling. And they did the modeling to try and look at, this is for South Africa, one country that's been very severely affected by HIV. And they did the modeling by trying to see what's the potential clinical and economic impacts of the cutback in the US support for HIV in South Africa, investments in South Africa. And they looked at if the funding goes down by 50% or it goes down to zero. And the predictions are quite dire. I think anticipated that you'll have potentially something like 500,000 more HIV infections and almost 600,000 more deaths from HIV, as well as a decrease in life expectancy in the country. So I think the effects could potentially be very severe and also can occur pretty rapidly as well. So why is it important to think about global health and to think about how important it is for us here in the United States? I think there's an interconnection between global health and local health that often is not appreciated. And I think it's short-sighted to not appreciate the value of the global work on our local decision-making, on our local investments, and vice versa. Just to not take the lessons we've learned locally and try to adapt them and adopt them elsewhere. So why does global health matter? I think in reality, we can't, of course, it's obvious to everybody in this room that we live in an interconnected world. And this is particularly acute, of course, for infectious diseases. We've seen with the COVID-19 pandemic where a variant could be identified in South Africa today, and in a week it will be in New York, and or faster. And similarly, I think we're seeing now what's happening in H5N1, but also other conditions as well, is that we are an interconnected world and we have to relate to each other as as one world. Of course, the issues around climate and displacement, they don't know borders. These are issues that affect communities across the world, and really cannot be contained to one geographic area. I think the huge importance, of course, of the economic effects, as well as the security and diplomacy effects. I think it's really important to think back about those difficult years, I call them, at the very beginning of my presentation, where there was a concern, of course, of if there are negative effects on populations elsewhere in the world, there will be economic effects. There could be collapse of communities and economies, and that will have an effect on us. It always has an effect on us. So I think it's important to also appreciate that these economic effects can be very dire, as well as security and diplomacy effects as well. I think the importance of discoveries and innovations. I cannot tell you how many innovations and discoveries we've that were identified somewhere else, and then they came to us, including self-testing, HIV self-testing, HIV rapid testing, scaled up much more in Africa, and then came to this country from there. The idea of multidisciplinary teams is something that we've adopted, and vice versa. So I think as we move forward, we have to appreciate that discoveries and innovations can come from anywhere around the world, and it's in our benefit to have those relationships, to be able to sustain them, but also to adopt them. It's very important to share experience and solutions, and I hope today I've shared with you some of these solutions and experiences, because I think these should inform what we do day in, day out. We're an interconnected world, and we learn from the world, and that helps to improve the health and well-being of our own population. And lastly, of course, just for the sake of empathy, generosity, compassion, thoughtfulness, and humanity, we have to think of ourselves not separate from the world. Global health includes us as well. So I'm going to end with a few conclusions. I think the tragedy of the HIV epidemic, importantly, really crystallized what is needed to address a major global health threat. It was so acute, it was so dire. It crystallized what should be done, what must be done. And we should take those lessons to heart. The public health triumph in the HIV response has rested on this focus on health systems. And that's also the most critical lesson, I think, from the global experiences. It's important to always remind everyone that much remains to be accomplished in getting to the end of AIDS. We have a long way to go. I showed you the data. And not only to the end of AIDS, but also in confronting the other global health threats that we are facing. A reminder, there's an indelible connection between local and global health. It's bidirectional and must always be bidirectional. And lastly, for this moment, I think we must stand strong, protect the gains that we've accomplished while working very hard towards achieving the health and well-being of all people from around the world. I want to end by thanking you all. I want to acknowledge, of course, the ICAP team in New York, all over the world, for all their devotion and amazing commitment. I want to acknowledge all of you, and I want to acknowledge as well the people that we've served over the past 20 years. Thank you.